Man, woman, birth, death, infinity.
Good afternoon, and welcome to the Your Health radio and television program on the radio at AM 1240 KNRY, AMP's cable television channel 24, and on the web at www.ampmedia.org. Join our rotating host and their informative guests live every Monday afternoon at 4 o'clock. The purpose of the Your Health radio and television program is to help get, make, and keep listeners and viewers like you healthy. And now, ladies and gentlemen, on with the program.
Your Health radio and television program. I am Dr. David Morwood. I am a board-certified plastic surgeon, and I appreciate very much you being here. My first guest, the illustrious, very busy neurosurgeon, Dragan Dimitrov. Dr. Dimitrov, thanks very much for being here today.
Thanks for having me, Dave. Appreciate the invitation.
Dr. Dimitrov, one of the issues that I have, or one of my missions, let's imagine a high school student watching or listening to this program. I want them to know how someone becomes a neurosurgeon. You know, you guys are, there's this allure about brain surgery and spinal surgery. You guys are considered to be sort of above the rest of the human populace. So how is it that someone becomes a neurosurgeon?
Well, it's a long process, that's for sure. And the first thing to mention is you really have to do it for the right reasons. There might be all kinds of allure, but it really has to be something that you're completely dedicated to. So the logistical steps are 4 years of college, 4 years of medical school, and then a residency training program.
Okay, so let me back up for one moment. So of course, everybody's got to finish high school.
Yeah.
And we expect that they're willing to work hard. They probably enjoy the sciences to a certain degree. So then it's 4 years of college, then 4 years of medical school.
Right.
And then what happens after that?
So it's a 6 or 7 year residency program. And the variable there is 1 or 2 years of research training. So that's the idea. And it's really those last years of the residency that really make a neurosurgeon. It's really the time where you learn all the skills that you then later apply. And for me, one of the most important things is it really teaches you a lot about yourself. So most good residency programs will really show you in painful detail where your weaknesses are and where your strengths are. And it really allows you to improve on yourself and makes you brutally honest about what your skills are and what you can do. Because one of the most important things as a neurosurgeon is you have to make sure that you don't step into situations that you can't handle or aren't ready to do. And it's that process that I think gives you that awareness.
Dr. Dimitrov, it's fascinating. When I hear you talk, it reminds me of training for the Olympics, an athlete just training for the Olympics, getting to know himself or herself, her strengths, his weaknesses, etc., for working towards a goal. It's amazing. So after 4 years of medical school, it's 6 or 7 years of training.
Right.
And that's what you call residency.
Right.
Now, is there an internship that, for example, in plastic surgery, I did a general surgery internship where I rotated through all the surgery specialties. Is that the same in neurosurgery or not?
Right. It's usually a 1 or 2 year internship. It's usually a surgical internship. So that's, in the past, it was a situation where you first applied for an internship, went through that, and then applied for your residency. More recently, it's become all lumped together as one. So when you apply for your residency, there's automatically the first 2 years built in are your internship.
Well, you know, I don't mind pointing out the fascinating thing to me is that the 3 specialties with the longest training periods are neurosurgery, cardiac surgery, and of course plastic and reconstructive surgery. 6 or 7 years after medical school. It's a long haul. But I think it's worth it, of course, and Dr. Dimitrov, one of the reasons I invited you to come onto the program, I know how hard you work and I know how dedicated you are to your patients, and I really admire the work you guys do. You know, it's interesting when a bunch of the guys may be sitting around trying to fix their car or watching a football game and somebody says, well, you know, it's not rocket science or brain surgery, and you say, actually, it is brain surgery. So you guys can actually operate on the brain or the spinal cord. And that's what I'd like to concentrate on today. is operating on the spinal cord and back pain and back disorders, etc. Now, before we go on to that specifically, tell us a little bit about your own individual training. Where did you grow up? Where did you go to medical school? Where did you do residency?
Sure. So I grew up in a small town called Pearl River, New York. That's in Rockland County. And
Is that upstate or down by the city?
That's about half an hour out of the city.
Okay.
And then I went to Montvale High School, which is right over the border in New Jersey. It's a good public high school, and that's where I got very good high school training. And then I went to Duke University for 4 years of undergraduate, and that's where I did my pre-medical. Then I went to New York University School of Medicine in New York, and then after that, I was actually bound towards cardiac surgery or even plastic surgery. I spent a considerable amount of time with microvascular suturing
Of course.
in the labs at NYU.
It's great stuff.
Mm-hmm.
Microsurgery is a lot of fun and rewarding and challenging.
Yep. So that's kind of how I got hooked into the whole microscopic world of sort of the fine detailed things under microscope. Then I applied for general surgery training, and I went to Washington University in St. Louis.
Mm-hmm.
For 2 years. That was one of the stellar general surgery programs. During that time, I had the opportunity to rotate on one of the neurosurgery services, and it was really the anatomy and the graphic detail of all the nerves and the complexity of it that really drew me towards that. And so that's sort of when I decided to shift gears from general surgery and potentially cardiac surgery towards neurosurgery. It was a bigger challenge. I don't know why at that time I wanted a bigger challenge, and
Well,
I certainly found it.
It's certainly a challenging field and fascinating. And you ended up doing your neurosurgery residency where?
So then I did my neurosurgery training back at Duke University. And so that's where I really learned what it was all about.
At Duke.
Mm-hmm.
Well, you know, Dr. Dimitrov, most of my audience knows that I was chief resident at USC. And the guys from Duke, we sort of tolerate. But had I known that, I may have changed my mind about inviting you. No, of course, I'm just kidding. So our important topic today, I want to talk about back pain. And I'm going to learn a lot during this program, I know. You know, I recently read something that upwards of 85% of Americans at one time in their life experience back pain bad enough that they'll have to change their activities for at least a day. 85% of the population experiencing debilitating back pain. It sounds like it's almost normal. Could you say that?
Right. Well, that's a great place to start, and it raised the interesting question of how does a neurosurgeon who trains to take out brain tumors and work on aneurysms and work on the spinal cord end up managing a lot of back pain and back problems. And the way that comes about is obviously we operate on the spine and the spinal cord, and like you mentioned, 80 to 85% of people will have an episode of back pain at some point in their life. The really important thing to know is that it's a very small percentage. It's maybe 5% or 1 or 2% of people that will actually require an operation. And that's a really important point to make. It's an interesting phenomenon to me as I've spent time in private practice that people with back pain, which is really better managed by someone who has expertise in musculoskeletal disorders, for example, gets referred to a neurosurgeon for a neurosurgical problem. What ends up being the case is as neurosurgeons, because we manage these things and we have to very carefully distinguish who will benefit and who won't from an operation, that we become really good at these sorts of things. But in an ideal world, Dave, it would be a situation where patients with back pain don't really know about surgery because it's not really a surgical problem, at least the vast majority of it. And they see a specialist who is able to manage the musculoskeletal end of things, but at the same time able to distinguish what is a critical or important clinical finding that should have them be referred to a neurosurgeon or someone with that training quickly.
Okay. One of the terms, Dr. Dimitrov, I've been teaching the audience about over the past few months is this term that all doctors use called workup, right? I want them to know really what a workup is. And
Right.
essentially that means to investigate the cause or try to find out why a patient is experiencing a certain symptom, right?
Right.
So let's start with the person or patient that's feeling back pain. When do they need to call their doctor, and when should they just say, take it easy and take some Motrin for a couple days? What do you advise, or when do you advise people to call their doctor?
Right. So in general, some of the key things that really distinguish someone who should make an appointment right away or go to the emergency room even are some of the emergent neurologic signs. And that's the part where I really become interested. And those are things that are usually defined as weakness of an extremity, where you can't move an arm or a leg, where you have sensory changes such as numbness or paresthesias, which is like a sense of tingling or prickling in your hands.
Right. Now let me interrupt for a second. Can you tell us what we mean by foot drop? What's a foot drop?
Right. So a foot drop is the muscles that allow you to lift your foot are the ones that are innervated by certain nerves in the back, usually the L4 and the L5 nerve root. Those are also the ones that are most commonly affected by a disc herniation. So a common pattern is someone that has a foot drop, and it's often caused by a disc herniation. So the typical thing that I see that's important to mention is the person who has back pain and has a foot drop. That's something that should be seen more urgently. So that's the distinction to make, Dave, is if someone has back pain as well as the neurologic findings, the foot drop, the weakness, the numbness, and the tingling that come along with it, that person needs to see a physician quickly, because if we get the pressure off that nerve, usually that function can be restored. If it goes on for a period of time, that becomes more difficult. Oftentimes I see patients who have tried to be super conservative about things, let's say, have dealt with the back pain, disregarded the neurologic symptoms, and then 2, 3, 4 months later, it's very difficult to restore that function, and it's a bit of a shame.
Okay, so in terms of educating our audience, for the person who experiences back pain doesn't automatically get an operation by any means,
right.
Certainly. But when they have what we call neurologic findings or neurologic signs of, say, a nerve dysfunction, then our antenna goes up. So
right.
That's the person that we need to see in the doctor's office. Is that right?
Right. That's definitely true. Now, that's in broad sweeping terms. There are a lot of details that are important, and it's hard in a 5-minute segment to describe all that in detail. That's why the best way for these things to be managed is if someone says, hey, I've got back pain that's troubling, something's really going on, in general, they should either come and seek help by a group of experts who work on these things as a group, sort of like a comprehensive spine center where all the specialists, whether it's an orthopedic spine problem, a neurosurgical problem, a musculoskeletal problem, a physical therapy problem, someone can address them all in one center. That's the ideal. Also, it's a great idea to go see your general medical doctor, which is a great place to start the workup. Those people, those physicians are really good at distinguishing who needs to go where. And if there's real neurosurgical problem, they'll call right away.
Okay. Now, Dr. Dimitrov, we could talk about any of these issues, I think, for hours. But in about the 5 or 6 minutes we have left, I want to take this out as an opportunity for me to learn something.
Sure.
So I want to talk about exactly what a discectomy is and,
sure.
and what we mean by a slip disc, and does it
sure.
really ever rupture? And if we have time, I want to talk about a lumbar laminectomy. You guys call it a lum-lam.
Sure.
And maybe spinal stenosis. So can we summarize those issues for people?
So those issues are all sort of tied together. They're all the key point to a disc herniation, to lumbar stenosis, and those diagnoses is that they all indicate that the term stenosis means narrowing. And so in neurosurgical terms, what we're talking about is narrowing around a nerve. So if a nerve is getting pinched, that gives you a constellation of neurologic findings and symptoms that people perceive. So the procedure, so in some cases it'll be bony narrowing, in some cases it'll be a disc herniation that ruptures through and pinches the nerve.
Now explain to us actually what a disc is. Is that a little wafer or a little like mini cushion or sponge? What's a disc?
The best way to describe it is a disc is a structure, it's a cartilage structure that separates the vertebral bodies of the spine, and they separate each and every vertebral body that we have in our bodies. And what they are is it's a spongy, soft center that then has a thicker cartilage covering. And it's the best way to think of that covering is kind of like a burlap sack. It's very strong, but the fibers can be worked apart. And sometimes in the process of degeneration or from other stresses that we don't fully understand, a piece can pop out, and that's called a herniated disc.
Now, is it when we use a slang term, a slipped disc, is that the same thing?
That's the same thing.
Oh, so that disc can sort of start to degenerate and come apart, and does it actually push against a nerve coming out of the cord or spinal cord, or does it actually push against the spinal cord?
So below lumbar number 1, there's usually only nerve roots. There's no more spinal cord. Those are more resilient. And it's actually, the spinal canal is a sac of spinal fluid with nerves traveling in it. So usually it's in that space, this sac with the nerves traveling in it, where the nerve gets pinched. It can also be as the nerve leaves what we call the foramen, which is the canal where it leaves the spinal canal. At that point, the nerve can also get pinched by a disc compressing it. It can be in either of those locations. Does that make some sense?
Well, it is starting to make sense. So is that similar or different than a lumbar laminectomy? If you do a discectomy, it's essentially removing part or all of that ruptured disc?
Here's my 2-second explanation for the difference between a discectomy and a laminectomy. So if you think of the lamina is the roof of the house where it's, or one border of the spinal canal. The disc is the other. And if the nerve is getting pinched, if it's not a ruptured disc, sometimes we just do a laminectomy. That means removing the roof to make space. In some cases, if the problem is the ruptured disc, then we not only remove some of the lamina, but we remove the ruptured disc underneath. So both are ways of decompressing the nerve. One involves just removing the bony and ligamentous elements. The other procedure involves removing the compressing disc from underneath.
So you physically, in surgery, you physically go in there and you open up the space for the nerve.
Right.
Well, it's unbelievable, and it's incredible to me how patients have to trust you and your instruments in your hands when you go in there and you open them up.
Yeah, I think that's a big part of the doctor-patient relationship is building that trust that it's a very intimate thing to be able to take someone's body and repair it in that way.
And spinal stenosis. Now, have we talked about that? Is that same thing, or is spinal stenosis a totally different?
Well, so they're all different parts of a spectrum. So a herniated disc, for example, is generally a situation that you think of where something's happened acutely. This piece of disc immediately popped out, pinched a nerve. The characteristic symptoms are pain in the back or buttocks that then radiate down the leg with a sense of numbness, tingling, and sometimes weakness into the leg, depending on if you have the full spectrum of nerve compression. That's an acute finding. Usually spinal stenosis is something that occurs more insidiously over time, such that the spinal canal is narrowed a little bit each day as part of the degenerative process, to the point where it gets to the point where the straw that broke the camel's back idea, that the nerves are so compressed that they're no longer conducting the signals correctly, and that brings on the nerve symptoms.
Dr. Dimitrov, I tell you, I've got to get you to come back on the program because I think this stuff is fascinating and we could talk about this for hours. Now we have just a couple of minutes left.
Sure.
I want to make sure I give out do you have a phone number? Do you have a website? Are you associated with a group?
Yeah, so I work as, we formed a group called Monterey Spine and Monterey Joint, and we're at 12 Upper Ragsdale
So you're
in Monterey.
So you're off
in Ryan
Highway
Ranch.
68, off Ryan Ranch. Okay, and the name of the group?
Monterey Spine and Joint, and we have a website if you Google that. And the whole concept of our clinic is that we've got orthopedic surgeons, both joint surgeons, orthopedic spine surgeons, conservative people who perform injections, people who focus on physical therapy, myself from the neurosurgical perspective. The point is that if a patient comes to our clinic, then we have the full complement of people that can, number one, diagnose the problem, because that's the most important step, is to figure out what's going on.
The workup.
The workup,
right? Okay.
And then manage the problem.
Okay.
The most common thing that I see is people come, they have treatments done without a clear diagnosis being made. And that's one of the biggest problems, especially surgery without a clear diagnosis. So the main goal of our clinic is anybody that has a spine problem, if you come in the door, we can figure it out and treat it, and that's the whole concept. And it's really the way that spine care should be done, I think, in the broader sense.
Well, Dr. Dimitrov, I certainly appreciate you coming on the program, and I really respect your expertise. I hope you come on again.
I'd love to.
I'd like to arrange that. Now, once again, Dr. Dragan Dimitrov, and once again, you're part of the What group?
Monterey Spine and Joint.
Monterey Spine and Joint, and you're right here off Highway 68.
Yep.
Well, I certainly appreciate you coming on, and like I said, please come on again. A
Great.
specialist in brain surgery and back pain and spinal surgery, et cetera.
That's right. Next time we'll have to talk about the brain part.
Love to. I'm Dr. David Morwood. I'm a board-certified plastic surgeon, and this is Your Health radio and television program. Thanks so much for being with us. We're coming right back after a very brief pause for a very good cause.